thank you for coming for this important event. You know, in the life of any country, there are times we need to engage in difficult discussions in order to find solutions. So today is part of that, starting a discussion in what has been a very systematic inequality that has been existing in mental health. So I'm not going to talk too much. We are going to kickstart, and Nena will introduce the next thing we are going to do in a minute while I sort out one or two things. Yeah, then over to you. Thank you.
Are you ready with the video?
Yes. Hold on, I'll just try to share the screen. Okay, so can you let them know the background of the video, please, before I keep putting it on?
Okay, we're going to be playing a mini documentary, obviously to set the scene. This is just some people's thoughts and experiences when it comes to mental health or inequalities in services for Black people. So yeah, you can go ahead. I think the video is quite well self-explanatory. So yeah, without further ado.
My name is Patricia Obitruko. I'm the founder-director of Wellbeing Connect Services. It's a mental health charity based in North London dealing with families. Our special area is advocacy support, but that advocacy support is specialist advocacy support. We offer to families, which at times include child protection issues, mediating with them, between them and the schools and any agencies, and then supporting them within the mental health system. So we are also a voice for the vulnerable. That's why you're hearing my voice.
Have you personally experienced unfair treatment or racism in the country?
Well, of course I have. I was just beginning to tell you. The first time I experienced it was at the Holy Name Roman Catholic Church. But that wasn't racism. I think that was envy. And after we moved from, was it Hugh Mossad, we went to Salford, and this girl in the class, you know, there was a lot of hate in her. And I said, "You don't like me?" She says, "No." And the next thing I know, I think it's the nuns, because it was a Roman Catholic girls' school, picked her out. And all the girls in the class cheered.
There was a time this year, in fact, just before the whole lockdown, where I was actually at work driving with a client, and I was pulled over by the police. And I said to the police, you know, I'm currently at work, I'm with a young person right now because I do mentoring in the community. And they said, well, that doesn't matter, you could still be a drug dealer. And I sort of like just paused and said to myself, drug dealer, like, what do you mean? I'm at work. I showed them my ID to prove that I'm at work, I'm with a young person. They asked us to get out of the car, we'll put in handcuffs. So you can imagine I'm at work, I'm putting handcuffs. My young person's put in handcuffs, they've searched my car, obviously they've not found anything. But I found that so embarrassing in terms of, you know, it made me think I'm at work, you know, trying to get on with my job. But even sometimes you could be doing the right thing, but sometimes that doesn't actually, I guess, hide the color of your skin, and that there is a level of racial profiling that happens and takes place in the UK consciously and unconsciously as well sometimes.
Once I was in my French class and there was only 2 Black girls in our French class, maybe 3, but I was the only Black, pretty much the only Black girl in my form class anyways. But in terms of going to, when I was in my French class, there was like a group of us and there was a Black girl and one about 10 different white boys, and one of them had asked her for a pen. And as she took out the pen, they just laughed to each other, saying, 1 minute they take out a pen, next minute they're taking out a knife. And there's many other instances of that where that has happened like around me. And I've had certain circumstances which have been said to my face, but we move from it, you know?
No.
I work in a predominantly Caucasian environment. I've been working in IT sales for probably the last 8 years. Predominantly when people hear my voice, they won't suspect that I'm from an ethnic background. However, once they meet me in person, that's where I see or I feel that the atmosphere in the room has completely changed.
Right.
To give you a great example, I went to last year. I had a meeting with a very high brand where you would say that this is probably one of the top 2 brands in the globe, based out in the Netherlands. I flew over the night before, obviously making sure there's no prejudgments about me. I made sure that I had, the appropriate dress code on lock. I made sure that I was correct and on time. Okay, when I entered the building, the 2 questions that they asked me at the front of the office was, who do you work for and why are you here? And when I explained to them who I work for and why I'm here, they automatically thought that was incorrect. So instantly I negated and I asked them, why is that important if I've already told you why I'm here? Why do you need to check my, because they asked me for my ID and my passport, which I gave to them because obviously I was thinking, well, do you know what, it's completely fine. I can understand it being a process if they'd ask everyone this, but it was only me that was picked on. So when they asked them the questions why it was, they couldn't even give me a great answer or a good reasoning. So that's one reason there, but there's what I mean that I've felt this prejudgment against ethnic minorities, especially against black men. I felt this in other situations and scenarios.
One of the incidences here, somebody called me and which was very embarrassing and embarrassing at work. But I make sure that I didn't leave it lying down the carpet. I have to take it to my manager. So yes, I have experienced it. Apart from being called names, I've been being snobbish, people non-responsive to you just because of your color. Yes, it does exist a lot at workplace.
My name is Ade Adeshina from Obe Community Trust, based in the London Borough of Enfield, and we have been in the borough since 1990, March 1990. Yes, certainly we have experienced inequality, systemic, I will say it again, I'll repeat it, systemic discrimination at a higher level than our other counterparts in the borough. We have experienced it and we've been marginalized. So the structure is there, but there is systemic discrimination within the structure. And if this is not addressed, it's just going to go on and it's going to lead to a place where the African community is going to be demanding their right, because we are equally a taxpayer in the borough.
Here in Enfield, Wellbeing Connect Services, which I founded 22 years ago, is the major Black mental health organization. But for years, we have struggled with getting equal allocation of funding. In as much as we provide critical services in the borough, but each time we are given shoestrings to support the communities, which is not even appropriate to pay staff or to do other things, So it is really sad compared with if you are to do impact assessment on the funding allocation in the borough, you will see that Black organizations are least funded in the whole borough. Some of them have come and gone. I've seen many Black organizations come and gone. Many Black organizations that are doing great work that couldn't expand what they're doing or their capacity because they are least funded. Okay. So it's really, really very, very saddening. And Black community are overrepresented in mental health institutions.
Our contribution is not valued as it ought to be valued, and the fundings to go with that is not even, it's just non-existent when it comes to African organizations and the Caribbean organizations. They're like a piecemeal. Tokenist injection is small all over the place, and the offices and all the people within the system are guilty of this. Not the other organization within the borough, because they also are doing their best, the best way they know how. It's the officers and the people at the gatekeeper that needs to know best and do the right thing. And this message, I believe, if it gets to them, they will be searching their conscience. They know it. And the statistics is not easy. It's not something that anyone could just be talking it. The statistic is on the Empathic website, it's on the NHS website. Google it, you will see it. But the other day I Googled one, and I looked back 20 years, and I could not see any African organization or the Caribbean organization receiving above 50,000 from the council. But I could see over 20 of other organizations that are not African or Caribbean receiving well over 200,000 from the council. So definitely, the majority that I see were the Africans are 5,000, 1,000, and 10,000 below, piecemeal. So that doesn't even cover rent to the council. If you rent a place from the council, it doesn't even cover rent, let alone cover service delivery. The
property where we're providing these services belongs to the council, and the council will charge you the same commercial rate that others are paying. So they will give you, let's say for example, they give you 20,000, they take about 14 or 15,000 out of it. By the time they put all other costs, waste, insurance, all of that, the whole money they've given you to provide services is gone.
If police are behind me while I'm driving, I'm always thinking, am I going to get stopped? Am I going to get stopped? And I'm not panicking because I've got anything in my car that I shouldn't have or anything illegal, but I do panic when police are driving behind me. I do panic and I do begin to think to myself, well, I could get stopped now. That's one way I think it's definitely affected me. I think it's increased my paranoia on the street.
In terms of my actual mental health, I wouldn't necessarily say like I was diagnosed with anything, but I did have a lot of anxiety just generally being a participant in my lessons. It really did kind of hold me back. So it definitely did bring those kind of feelings up, but thank God it was nothing which I'd say I was diagnosed.
There's a lot need to be done when it comes to the Black Africans and the Caribbean community of this, but there's a lot more need to be done to actually start rising from the arches, let alone to think of meeting their counterparts, other sectors within the borough. They know the statistics, they know the fundings, they know where the fundings are going in the borough. So I don't need to tell them. We have the statistics. It's actually open statistic that is on MV Council website, it's on NHS website, who they fund, where their commissioning goes to. And we've been saying therefore, why are they not commissioning us? Why are they not funding us adequately enough? But yet when we say that, we are like a troublemaker.
It's really, really sad what we have been experiencing and what our clients have been experiencing, because some of them have a tendency for suicidal thoughts. Some of them have family issues and challenges with schools for their children and all that. And we also get involved in managing crisis.
We need more places like Wellbeing Connect Surface where they can identify with your struggle more, because it's talking to your own people in it. Like other races don't really understand the stuff we're going through because they don't go through it. But people of colour go through a lot, and it's good that if you've got somewhere to go to talk about it, like this Wellbeing Connect Surface, it's good to be able to express how you feel to your own colour, people of your own colour, because they understand more. So it's a good thing that we've got this it helps a lot.
But I like to say, coming to Wellbeing Connect Services, Ebony's people, it's been a great help to me, yeah.
If I have a magic wand, I tell them fund us properly. I tell the council treat us equally. I tell the CCG to ensure that the funding goes to us so that we can continue to provide the quality services we're providing. You know, some of the mainstream services that are being provided, you know, the Black community are not accessing it. So I believe that we have the key. We have the key to our community. We have the key to carry our community to the mainstream. That is why we are bridge builders. So they will benefit a lot by investing in organizations like us.
Well, I do hope you enjoy this presentation, which is put together by Wellbeing Connect, an NGO, a charitable status organization, rendering services to the Black and ethnic communities, especially in the north part of London.
And we're just going to go straight into our first speaker of today, who is going to be talking about race, ethnicity, and criminal justice system on the health and well-being of Black people. He is Des Brown, the CEO of Greenleaf Trust and founder and director of Spark to Life, a community-inspired initiative that empowers and advocates for offenders and those at risk of offending. Des is a qualified person-centered therapist and ordained minister and has served as a prison chaplain. He is a gifted communicator and regularly delivers training and bespoke sessions at conferences, events in prisons in the UK. Des is one of 2 appointed BME specialists for the CLIN's Third Sector Advisory Board for Reducing Reoffending that advises the government on issues to do with prison and probation. Wow. Over to you, Des.
Okay, good morning, everybody. It's a great pleasure to be joining this conference this morning. I'm going to share my screen. I've got a lot of slides, but I'll whistle stop through them all, and I'll make the slides available afterwards via the people that are running the running the conference. So here we go. Hopefully everybody can see that. If you can't, I'm sure the host will let me know. So just looking, as it's already been mentioned, at race and ethnicity within the criminal justice system, specifically at the health and well-being of BAME people, especially Black people. One of the things I want to kind of mention is that I acknowledge that the term BAME can be problematic as it refers to a group of people who are far from homogenous. But the intersection of race, ethnicity, faith, and culture makes social identities multifaceted and shifting. So the experiences of individuals within these groups will vary. Wherever possible, I seek to be specific when describing groups of people, but at times use the term BAME, albeit reluctantly, to describe inequality and discrimination across the groups when necessary. I've already been introduced, so I won't go into any of that. The only thing I would add is that I done my placement as a therapist in Pentonville prison, which was quite helpful. So obviously when we come to a conference and someone speaks or we share, we'll come with a worldview. And Steve Covey said, we see the world the way that we are, not the way that it is. And there's a concept within therapy called phenomenology, which is the philosophy stroke theory of our experience and our consciousness. So we all have a phenomenology, we all have a worldview, and the worldview is based on the way we are, not the way that it is. So people's experiences are really important. In July 2016, Theresa May said, if you're Black, you're treated more harshly by the criminal justice system than if you're white. So it's been acknowledged within high government level, within the Prime Minister at the time, that obviously Black people are treated different. So what do we know about the criminal justice system? There's been successive reviews in the criminal justice system over many years looking at the treatment and the outcomes for Black, Asian, minority ethnic people. And they've demonstrated the disproportionality that our community face, and individuals in the system, the poor outcomes that they face. So there's a Lord Bradley's Review 2009, which looks specifically at disproportionality and mental health within the criminal justice system. Also, we've got the Young Review, the Taylor Review, and the Lamb Review, and these, again, can all be accessed online. When, for instance, we're looking at examples of emerging findings published by the Lamb Review in 2016, it pinpointed specific stages of the criminal justice system at which disproportionality occurs. So young black males, for instance, are 3 times more likely to be arrested, 10.5 times more likely to be arrested for robbery than young white males. Black, Asian, minority ethnic people are more likely to be convicted at magistrates court, have their case sent to Crown Court and be sent to prison from Crown Court. For every 100 white women given custodial sentences for drug offences, 227 black women are sentenced to custody for the same offence. And once in prison, BAME men are 50% more likely to have adjudications brought against them. So when we're looking at mental health and the intersection of the criminal justice system and mental health, there was a joint briefing done by NACRO, CLINCS, the Race Equality Foundation, and the Association of Mental Health Providers in August 2017, called Moving Forward. And what it found was, and it's, again, you can get this online, it's worth a read. It says people from Black, Asian, minority and ethnic groups are disproportionately represented at all stages of the criminal justice system. And it says the Equality and Human Rights Commission has stated that there is greater disproportionality in the number of black people in prisons in the UK than in the United States, which may raise some eyebrows. Additionally, research studies and data monitoring have consistently shown that those from black communities, in particular, all those overrepresented across mental health services. So this anomaly is compounded by the fact that both systems seriously disadvantage black people. So studies also highlight that different ethnic groups have different rates and experiences of mental health problems, which reflect their different culture. And I think this is important for us to understand: cultural and socio-economic context and access to culturally appropriate services. So when we talked, or when I introduced at the beginning about being Black, Asian, minority, ethnic, when you begin to break that down, because we're not a homogenous group, you begin to see that there are differences within people's ethnicity, different cultural experiences. So for example, African Caribbean people living in the UK have lower rates of common mental health disorders, but are 3 to 5 times more likely to be diagnosed with and admitted to hospital for schizophrenia. So in general, people from BAME groups living in the UK are more likely to be diagnosed with mental health problems, more likely to be diagnosed and admitted to hospital, more likely to experience a poor outcome from treatment, and more likely to disengage from mainstream mental health services, leading to social exclusion, deterioration in the mental health. Probably much of what I'm sharing people will know, but I think it's good at the beginning of the conference to contextualize what a lot of the speakers are probably going to be building on, which is there is clear evidence and data to support the disproportionality and in many ways the injustices that are experienced by people of colour within the criminal justice system. So they, in their research, the reasons for the disparity will include, and this is a few things: the impact of migration, including trauma in country of origin. I'll be talking a lot about trauma in a moment. The complications in navigating the migration process and hostile responses in the host country. So people coming over to the UK, the United Kingdom and Britain, and just the trauma of the migration and the journey, but then experiencing levels of hostility. There's material and socio-economic disadvantage, including reduced access to employment and housing, again can compound the stresses and pressures around someone's mental health and mental well-being, and the experience of racism and or exclusion. So the Bradley Review reviewed people with mental health problems or learning disabilities in the criminal justice system, found that people from BAME communities are 40% more likely than white Britons to access mental health services via a criminal justice gateway. So their findings and their concerns and their recommendations, and there's over 16 recommendations that was given to the government, how they can address the issues of mental health within the criminal justice system. So discrimination and differences underpin the negative experiences of people from BAME communities across the criminal justice system. and mental health services. Although further measures need to be taken to address disadvantages and discrimination, the following recommendations focus specifically on actions to address disproportionality in health in the justice system. They are grouped in 4 areas. They need appropriate services, services that are person-centered, that are culturally competent, and that are relevant to the service users. Data, there isn't enough data out there to be able to best serve the service users that we're trying to reach. And so they need to be intentional about collecting the data, specifically around whether it's Black people from African or Caribbean backgrounds, whether it's dealing with Asian people, etc. The workforce and training is really important, whether it's training around unconscious bias, whether it's training around understanding the impact of trauma, etc. That needs to happen across the workforce. Involving people with lived experience is a non-negotiable. Often it's being done too, and they're not involved in the actual planning and the outworking of services. And there needs to be integrated working. So the voluntary sector needs to be central at helping deliver these services and shaping these services for the client group, because more often than not, the voluntary sector is the community, part of the community, and we'll have people with lived experience serving within the program stroke charity. So I'm looking now specifically at bridging the gap in health and inequalities of BAME communities within the mental health and social care settings, which is really the title of today's conference. So I've taken it from a concept called ABC of ACEs, and ACEs stands for Adverse Childhood Experiences. But you and I know that, albeit we can look at children, and a lot of our service delivery is with young people within the criminal justice system, or young people that are disenfranchised from mainstream society. We work with medium to high risk offenders, and we look at the ABC of ACEs, which is A is to accept that everybody has experienced trauma. And trauma is a deeply distressing or disturbing experience. Let me just reiterate that, a deeply distressing or disturbing experience. So someone's phenomenology, which is their worldview based on their experience that affects their conscience and their consciousness. If someone's gone through a traumatic experience, it will affect my worldview and my consciousness. So I will be more, the way that I filter things or interact with services will be affected by my experiences. But we have to accept that everybody has experienced a deeply distressing or disturbing experience at some point in their life. Once it becomes around issues of engaging the criminal justice system or engaging the NHS around mental health, and it's traumatic, they will then have a voice to speak into that. And this in turn will become the behavior. It will affect their behavior. And I think us as professionals, what we need to be mindful of is we need to be curious. We need to be asking, again, relevant questions, because I need to and I want to understand. And that's where our empathic approach comes in. So the ABC of ACEs. So we need to stop pathologizing, which is looking at a group of people and thinking, are they psychologically abnormal? And what I mean by that is when you look at colonialism, when you look at institutional racism, and you look at slavery historically, it was built on saying that people of color were psychologically or physically different and abnormal and was not fully human. And we've got to be very careful that when we start looking at disproportionality and numbers that are high, that we can challenge the system and say it's because of systemic racism, it's because of inequalities, and it's not because there is something different with people of color, for argument's sake. So this enables us to ask, what has happened to you? I think one of the big approaches with a trauma-informed approach that is different from a medical approach will look at your symptoms and try and medicate them. A trauma-informed approach will look at your symptoms and not seek to initially medicate them, but to ask the question, what has happened to you? Why are, you are presenting a certain way because something's happened. There isn't something wrong with you, something's gone on. And I think having a trauma-informed approach when we're working within the care sector enables us to give permission, gives us permission, shall I say, to be kind to others and ourselves, our colleagues and our friends, because all of us experience challenges and trauma in some way or form. So Stephen Covey said this: most people do not listen with the intent to understand, they listen with the intent to reply. And we need to come from a premise of, I need to understand, and this is the kind of message that we need to convey. So when we're looking at a trauma-informed practice, we're looking at a few things here. First and foremost, we need to create an environment for service users that creates safety and trustworthiness. So if I'm working with somebody who has issues around mental health, I'm aware of the disproportionality, the discrimination, and the institutional racism, I need to make sure my service creates a level of safety and trustworthiness, which means it's person-centered and it's built on relationship, not transactional. And I'll come and talk about that in closing. So also I've got to be mindful that the opportunity for choice and collaboration with people that I'm working with, have they got a voice in the service? Have they got a choice, or is it a service that is being done to them? Or is there an opportunity to collaborate? Is there an opportunity to see what options they have to receive a service that is better suited to them? Because more often than not, it's prescribed on them and it's very generic. And as you and I know, people are different and people need different services stroke solutions to their issues. And I think ultimately as well, we need to be coming from a strength-based and skill-based approach. So I need to be looking at their strengths, not looking at the false negative, which is the referral form, which highlights all the things that they've done wrong and all the problems that they have. And I don't see them as a whole person. If I'm not careful, I'll see them as a problem. And that's not healthy when we're looking at having a trauma-informed approach. The truth is we all go through stress. There's positive stress. Positive stress could be like me presenting today. I'm feeling slightly anxious, or, you know, if I've got a driving test, I might not feel, I could feel slightly, nervous about it. That's positive stress. That prepares me to maybe deliver or bring on my A game, for want of a better term. Tolerable stress is things that we all go through. We may have heard some news recently about a loved one or someone we care for being diagnosed with COVID-19, for argument's sake, or some ill health. And these are things that as, families or in communities, we can support one another. That's tolerable stress. When we're looking at toxic stress, we're looking at prolonged activation of stress responses in the absence of protective relationships. And this is key, because I think as a service providers and as professionals, what we want to be offering is protective factor. We want to be part of that protective factor. Within Spark to Life, we're very much around advocating for the service users. We want to be that bridge between them and the professionals to constructively challenge the system when we feel the system is either being disproportionate in its outworking of punishment, and focus more on rehabilitation. But what toxic stress that is prolonged does, it affects the frontal cortex of a young person or of an adult, and it means that they lack an ability to reason or make decisions clearly. Now, if I'm aware of this and I'm trauma informed and I'm trauma aware, it may mean I'll respond differently to somebody who's going through toxic stress. And there's a lot of great parents that are supporting children, but they're experiencing a lot of toxic stress. And we just need to be aware that it's a whole family approach when we're looking at addressing issues around mental ill health. There was a survey done in 1992, or a concept coined, that adverse childhood experience, and a questionnaire was birthed out of that. And because of time, I'm not going to go into that, but they looked at 10 at that time, key indicators that would determine whether somebody has experienced adverse childhood experience. And this would come under physical abuse, emotional abuse, or sexual abuse. It would be neglect, physical or emotional neglect, and it would be mental illness, mother treated violently or husband, divorce, substance abuse, or incarcerated relative. If any of these things are happening within a family, a household, and a young person is brought up in that context, it is deemed that these are stress factors. These can be traumatic. And if 4 or more of these experiences happen, it raises the probability of that young person outworking symptoms that can affect their decision-making and their lifestyle choices. Some of the things we can add on to that now in 2020 is things like witnessing community violence, risk of homelessness, poverty, discrimination, bullying, long-term illness, loss of a caregiver, or natural disaster or war. And we heard from some of the testimonies in the video there at the beginning, and even myself working with young people that have migrated over here, or they may be first generation. There's a lot of people from our community that have experienced, whether it's that poverty, that homelessness, that bullying, the witnessing community violence, etc., even coming from natural disaster, that will add to their trauma And that deeply distressing or disturbing experience, when compounded with issues of poverty or homelessness, can affect someone's mental health, that it can become a mental ill health. Because of time, I'm going to skip this. But what I do want to mention is there's some research done called Epigenetics, and it talks about the genes that regulate our stress responses, and they can be altered by excessive stress, and the stress response becomes reset on high for life, promoting inflammation and can lead to disease and ill health. Now, what's interesting, they determined epigenetics, or this whole concept, and it is evidence-based, around people that had gone through the Holocaust, and they looked at their generation or their family from one generation to the next. What's interesting with epigenetics is if you think of people that have gone through slavery, and we're only talking maybe our great-grandparents, and for some, our grandparents' generation away, that actually the continual stress that they had gone through generation after generation can affect someone's genes and can affect someone's mental health, emotional health, and physical well-being. And I think this is important when we're looking to advocate for our community, because there's a sense of injustice that has happened, and there needs to be some kind of restoration. So again, because of time, I won't go through this, but what I will say, and these slides will be available, is that it shows the probability when someone has 4 or more ACEs of various different things, whether it's smoking cigarettes, alcohol, violence, crack cocaine, heroin. And again, this isn't anecdotal, this is evidence-based. It's been looked into. So if someone is cultural competent, and I believe as services we need to be definitely informed and aware around different cultures, different ethnicities that we're working with, and how we can best serve them, whether it's around the criminal justice system, stroke, their mental ill health, or the challenges that they have. There's a lot of people that we work with that may have been stabbed, they may carry a weapon, and sometimes people can ask the question, well, why are they doing that? But if, for instance, some of them will feel every day they leave their house, there is a threat or a fear of their life being taken. That's why some of them may use terminologies like it's like they're in a war. But the truth is, if you and I, when we leave this conference and we go about our daily business, we're not scared of going to the shop or traveling across a borough or across London. If that's what's happening to a young person, that is, they are experiencing traumatic, and for them to self-medicate, they may use drugs, they may get involved in risky relationships, risky behaviors, etc. And I think it's really important that we are mindful of those stress factors. Understanding faith as a discussion is really important, and the research identifies that faith for especially people from our community can become a protective factor. So that needs to stay on the table, because otherwise we're doing a disservice to people's heritage and their wider family and their history. We need to be client-centered. So the starting point is not our worldview, it's their worldview. How do they see the world? What experiences have they gone through? It's not looking at the false negative, like I said, which is all the things that necessarily has been presented that they've done wrong in a referral form. It's working from a strength-based approach. And the system, we need to challenge it so it's not risk-averse and making decisions that are stopping someone's development or opportunities because they're making a decision based on risk, not based on a person-centered approach, not based on a strength-based approach. And holistically, we need to approach this holistically. Body, soul, and spirit, the whole person. We're not just looking at behavior modification. People will navigate the system with behavior modification. Whereas if we look at someone's beliefs, their beliefs determines their behavior. That determines how they outwork decisions in life. And barriers and concerns for BAME-led services are very much a recommendation from the Lamb Review is that they need to be funded and they need to be more integrated within statutory services. And last but not least, we can't be clinical or transactional. We need to be relational in our approach. And there's a lot of studies around people of color and the communities and how they better interact, not necessarily with a Western colonized kind of approach to relationships or to transactional interactions, but actually a lot more relational, a lot more community-based. My final quotes are, we think sometimes that poverty is only being hungry, naked, and homeless. The poverty of being unwanted, unloved, and uncared for is the greatest poverty, Mother Teresa said. Probably one of my heroes, Brian Stevenson, says this: He's a civil rights lawyer in the South of America fighting for justice for those on death row. And he said this: you can be properly convicted, but unfairly sentenced. And I think that would be my standpoint when we're looking at the criminal justice system. We're not trying to change people's convictions unless they are unfairly convicted, but often they can be unfairly sentenced or unfairly treated. I hope that's informative and helpful. And yeah, thank you. As I said, I'll make the slides available later.
Wow, thank you very much, Des, for that. We really appreciate that. And like you said, we're going to make the slides available to all who has requested it. For those who just joined us, we want to welcome you. Our next speaker, her name is Dr. Shadee Olajubu. She is a consultant forensic psychiatrist. She has worked within the NHS for over 30 years. She's a senior mental health professional, and she has worked both in Nigeria and the United Kingdom in a variety of mental health settings. She's currently working for the NHS as a consultant forensic psychiatrist, working in secure services in Kent. She has also worked in medical education and is the forensic training program director for Health Education England. She is an accredited therapist in cognitive analytic therapy. She's also an honorary senior lecturer with Christ Church University, Kent. She is a mentor for a number of female professionals within and outside of her profession. She is passionate about mental health provision for Black, Asian, and minority ethnic people. Thank you very much, Dr. Fola, for joining us. And we're going to ask you to unmute yourself so you can do your presentation. Thank you so much.
Good morning, distinguished ladies and gentlemen. It's such a privilege and an honor to be here. And I just want to start by saying thank you first and foremost to Mrs. Obichukwu and her organization for inviting me to speak today. And also I want to say a really big thank you to Des. I found your presentation very informative. And as people who've been here from the beginning, I am going to touch on some similar themes. At this point, I'm going to try and share my screen. And I'm just wondering if there's a way of letting me know if my screen is being shared, please.
Yeah, we can see it.
Fantastic. Okay. So, as I said, I'd like to start by thanking Mrs. Obichukwu for the honor of being here today. I'm not going to repeat who I am because that's been described adequately. And so I just want to start by saying that today I think that this conference is really aptly titled, Bridging the Gap in Healthy Inequalities of Black Communities Within Mental Health and Social Settings. And so I started by saying that the World Mental Health Day, which is actually falls on a Saturday this year, is a program by the World Mental Health Federation, and it was commenced on October the 10th, 1992. And this year's theme is Mental Health for All, Greater Investment and Greater Access, Everyone and Everywhere. So what message is the World Health Federation trying to communicate? I went to check that out, and the president of WMHF noted that the individuals the world over face unprecedented challenges to their mental health as the world grapples with COVID. And there is no doubt that this is a pandemic unlike any seen in our generation, whose tentacles have insidiously extended to every facet of our lives, wreaking havoc and causing worsening health in its wake. And when I say worsening health, it's not just the absence of infirmity, but a state of physical, mental, and social well-being, which is the definition of health as given by the WHO. As a senior mental health practitioner, I have seen firsthand how COVID has precipitated heightened isolation, fear, emotional distress and trauma, anxiety, relationship breakdown. I just want to bring up the slides. Bereavement, trauma, and a general worsening of mental health in peoples of all ethnicities as people grapple with the knock-on effect of living with COVID. It is the exemplification of what I call the strange situation, where every day individuals are facing disease, destitution, and death, against the backdrop of very necessary infringements of our civil liberties to try and curtail the spread of the virus. Tentatively getting on a train about a week ago, I looked around the carriage with everybody donning masks and attempting to social distance. And I thought of how we look like actors and actresses in a sci-fi movie. But this is anything but fantasy, and this is anything but entertaining. This is an extremely frightening reality impacting on every aspect of our lifestyle and our mental well-being. At this point, I just want to highlight that even before COVID came onto the scene, mental health statistics were rather dire. There are 450 million people who live with mental disorders worldwide. Mental disorders are the leading cause of ill health and disability worldwide. 1 person in 4 will be affected by mental health disorders in their lifetime. Mental disorder and substance abuse accounts for 13% of the global health burden. Every 40 seconds, somebody somewhere dies from suicide. Over 800,000 people die globally from suicide annually, and suicide is the leading cause of death of males in the UK between the age of 20 and 49. However, COVID has once again highlighted inequalities with worsening health indices for individuals of BAME origins. I'm not going to define BAME because Des did a great job of doing that. It is a known fact, though, that in race-conscious societies, the non-dominant racial groups have worse global health than the dominant racial group. To quote Professor David R. Williams, Professor of Public Health, Harvard University, "We're in the same storm, but we're riding in different boats." So, important influences on BAME communities' mental health in all populations, UK included, are as follows: racism and discrimination, social and economic inequalities, mental health stigma, the criminal justice system, and some other factors which I'll refer to later. The interplay between these factors and mental health are complex, and they're not necessarily linear in causation. Safe to say, BAME individuals are exposed to increased economic, social, racial, physical stressors, which have a deleterious impact on health, be it social, physical, or mental health. And we've heard Des talk quite explicitly about trauma. So at this point, I feel it's really important to actually just describe some key definitions, because whether we like it or not, racism has a main role to play in our experience of mental health as BAME individuals. So, racism, it can be defined as prejudice, discrimination, or antagonism directed against a person or people on the basis of their membership of a particular racial or ethnic group, typically one that is a minority or marginalized. Inherent advantages, possessed by a white person on the basis of their race in a society characterized by racial inequality and injustice. So simply put, we're being discriminated against due to the color of our skin and due to our ethnicity. Second definition, white privilege. It's inherent advantages possessed by a white person on the basis of their race in a society characterized by racial inequality and injustice. And finally, microaggressions. And I think this is the one that many people who are not from our BAME communities find really difficult to understand. They are statements or actions or incidents regarded as an instance of indirect, subtle, or unintentional discrimination against members of a marginalized group, such as racial or ethnic minority. And I'm actually going to give some examples of microaggressions for our white colleagues. So, unfairly given the jobs that no one else wants to do. When different opinions are helpful, ours are not sought or asked for. We are watched more closely than others. Supervisors and co-workers use racial or ethnic slurs or jokes. We feel that we have to work twice as hard as others. We are often ignored or not taken seriously by our line managers. Others often assume that we work in a lower status job than we do and treat us as such. And I'm going to give a personal example of that. A co-worker with less experience and less qualifications gets promoted before us, and we are often unfairly humiliated in front of others at work. And that is based on a study by Professor Williams et al. At Yes Health Study. And just to give that example, a very live one that I have experienced. So as was explained, one of my roles is I'm a consultant forensic psychiatrist working in one of the main secure service in Kent. And I always remember a couple of years ago, there had been a service reconfiguration and I was heading up a ward round and my patient was white and his family joined the ward round. Now, I'm almost sure that when I introduced myself as a doctor, I introduced myself as a consultant, I introduced myself as a responsible clinician, and I had my name badge on. But possibly because I was sitting behind a laptop and I was jointly chairing the meeting and taking minutes, it was assumed that I must be admin staff. Now, there is nothing wrong with being an administrator. It is a completely honorable job. But it was very interesting to me that the patient's carers just couldn't equate me with being the consultant. So at the end of all the discussion, they asked a question that could only be answered by the person who was ultimately responsible for their son's care, myself. And they turned to the white colleague in the room who was a nurse. I don't really know who was more embarrassed, other members of the multidisciplinary team or the nurse herself, when she highlighted that the response that they needed was from the responsible clinician, and that was I. Of course, if a year later, when I managed to get the patient discharged after him being in hospital for about 10 years, a rather derogatory comment was made by the parent's father. "Oh, you're quite clever, aren't you?" Now, these are the kind of microaggressions that we face every day, which impact on our mental health. But it gets worse. So, looking at social economic disparities, again, Des has touched on them, but social well-being and health will impact on your mental health. So these are the things that we face. BAME populations are predominantly living in the most deprived areas of UK. There is a marked disparity in wealth generation. 16 to 24-year-old unemployment rates are highest in BAME populations. BAME individuals are paid less in comparison to white counterparts with equivalent education and qualifications. There is an increased in prevalence in homelessness. 37% of statutory homelessness is from BAME backgrounds. We have poorer maternal mortality rates amongst BAME women. There are also poorer infant mortality rates in BAME populations. Because of toxic stress, which Des has explained, we have a higher prevalence of obesity, hypertension, diabetes, and other mental disorders. Our life expectancy is lower. And of course, you have to have been hiding under a rock if you don't know that for us, we have worse outcomes in relation to COVID-19. And then we have to think about mental health and stigma. Ignorance and stigma, and now I'm going to kind of switch because I think it is important to actually say that ignorance and stigma are still the two elephants in the room when it comes to mental health and mental illness. I believe that people from BAME backgrounds still require some considerable education around mental health literacy and practical support to raise awareness of mental health conditions and combat stigma. There is a need for improving information about services and access pathways. Healthcare providers do need relevant training and support in developing effective communication strategies to deliver individually tailored and culturally sensitive care. Improved engagement with people from BAME backgrounds in the development and the delivery of culturally appropriate mental health services, hopefully could facilitate better understanding of mental health conditions and improve access. However, it must be noted that we from BAME populations have a more negative experience of services, leading us to disengage and consequently increasing the risk of compulsory detentions under the Mental Health Act 1983. Des has spoken so articulately about the criminal justice system, but I just want to highlight a few things. So I'm going to refer to some MOJ statistics, by that I mean the Ministry of Justice, and I'm also going to focus on some of the findings of the David Lammy Review 2017. So I think the key thing to highlight first and foremost that as a people, and we're not a homogeneous people, but we do make up 14% overall of the UK general population. And the Lammy Review highlights that those who are charged, tried and punished
are still disproportionately likely to come from minority communities. The report notes that there is a racial stereotyping of young Black men as dangerous, violent, and volatile. And Black men with mental health difficulties are seen as mad, bad, and dangerous. Therefore, Black people with mental health issues face double discrimination. So I just want to highlight some of the statistics. Some of them I'll be repeating, Des. BAME individuals make up 25% of the prison population, even though we only make up 14% of the general UK population. Over 40% of young people are from BAME populations in prison. BAMEs experience differential treatment. A BAME defendant is more likely to attract a custodial sentence. BAME populations, we are 3 times more likely to be arrested, 9 times more likely to be stopped and searched, 5 times more likely to have force used against us by police, and Black people are twice more likely to die in police custody. And quite worryingly, we're more likely to access mental health services through the police or the criminal justice system. Just a few other factors which impact on our mental health. The following also impact. And part of it is the cultural perception of and access to interventions in the following domains. So disability, matters around sexuality, gender issues, and the prevalence of domestic violence, and services to address all of those. So, as you know, I'm a psychiatrist, and I want to bring you back to the sad reality in terms of some statistics about mental health or mental illness. So the ASOP study was an etiology and ethnicity in schizophrenia and other psychosis study. It's one of the largest studies in this country, and it highlighted the following. The risk of psychosis in Black Caribbean groups is 7 times higher in comparison to white populations. There is a 9-fold increase of developing schizophrenia in Black Caribbeans as compared to white British populations. There's a 5.8 increased risk of developing schizophrenia in Black Africans as compared to the white population. And there is a 1.4 increased risk of developing schizophrenia in Asians who are designated South Asians, such as Bangladeshis, in comparison to the white British population. And it's clear to see that amongst one of the hallmarks is the fact that we experience much higher levels of trauma. The Mental Health Foundation also highlighted the following. Detention rates for Black British people are 4 times higher than white counterparts, even though we are only 14% of the general population. And although suicide generally is higher in Caucasians, it has been found specifically that there are higher suicide rates in young Black men, Black middle-aged men, and South Asian women in comparison with their white counterparts. So, coming back to today's theme, the aim of the theme for this year's World Mental Health Theme is to promote a focus on universal health coverage, which is a key target in the Sustainable Development Goal for good health and well-being. This is one of the 17 Sustainable Development Goals identified by the United Nations to improve our world. The World Mental Health Federation articulates this as follows: that all people have access to quality mental health services they need, when and where they need them, without financial hardship. The Director General of WHO has stated that mental health must be an integral part of the universal health coverage. And to quote the Department of Mental Health, there really can be no health without mental health. At this stage, I'm going to take you a bit on memory lane. I recall that I was present when the former Prime Minister, Theresa May, delivered the annual Charity Commission lecture in January 2017. She said that true parity for mental and physical health could only be achieved if every institution recognized the vital role it can play in delivering this objective. During her speech, she said, and I quote, "For too long, mental illness has been something of a hidden injustice in our country, shrouded in a completely unacceptable stigma and dangerously disregarded as a secondary issue to physical health. Yet, left unaddressed, it destroys lives. It separates people from each other and deepens the divisions within our society. Changing this goes right to the heart of our humanity, to the heart of the kind of country we are, the values we share, the attitudes we hold, and our determination to come together and support each other. And she went on to say, I want us to employ the power of government as a force for good to transform the way we deal with mental health problems right across society and at every stage of life. However, I recall very vividly coming out of that meeting feeling quite frustrated, because when she set out her agenda, there was no mention of a targeted focus on BAME populations. So I want to highlight what have been identified in various studies as some general barriers to service provision. One, recognition, I beg your pardon, so waiting times. No, I'll just go back a bit. So I want to first talk about the personal barriers. So these include a recognition of mental health difficulties. So that's individuals recognizing that they are struggling with their mental health. It involves social networks. So I read a study where a young woman was interviewed, and she said that nobody in her social network had even understood the concept of depression. Then there are sex differences, by that I mean gender. So males are less likely to talk about their mental health difficulties, and by extension, less likely to actively seek out mental health services independently. Of course, we've talked about cultural identity and stigma, and also financial factors. So for example, as Des rightly spoke about, ideally when you have a mental health difficulty, the starting point shouldn't actually be medication. And I say that as a senior practitioner who is a medical doctor. Many times when you have a mental health difficulty, you might, however, need therapy of some form, so a trauma-based therapy or psychotherapy. And unfortunately, the waiting lists in NHS are this wide. And when people try and access them privately, they are incredibly expensive. Talking about barriers, service provision barriers, well, there's quite a long list, but I'll start with a few. So waiting times, the waiting times for accessing services, for example, psychotherapy, are ridiculous. The issue of language, so not everybody has English as their first language, and there is inadequate provision of interpreters to facilitate meaningful communication. And I go on to the next point, because of course, the next barrier is communication between different service providers and stakeholders. Service provision barriers, being responsive to needs, and we've highlighted that today about the need for culturally sensitive and appropriate services. The issue of power and authority, and very aligned to that, of course, is systemic racism. And then there is, again, cultural naivety, insensitivity and discrimination, and even an awareness of what services need to be provided. I know Des noted this previously, but I'll say it again. There is a need for cultural competency. So research points to a strong need for greatly increased cultural competency in mental health services. And this may include some of the following: practical improvements in language, interpreting, translating, I beg your pardon, and literacy support. Des spoke about faith. So meeting faith-related and religious needs, very important for us from BAME backgrounds. Culturally appropriate food. You're going to a day center or residential placement, and yet the food is not culturally appropriate. Gender-specific services and staff, and definitely increased diversity of staff. It is I think it's almost impossible to work efficiently in providing mental health services without diversity of staff understanding various cultures. I believe there must also be positive actions to address and reduce the experience of racism and discrimination. I'm going to say it over and over again. I'm reminded that I think it was in 2012, commissioning for mental health services was reconfigured in this country with the introduction of integrated care through the clinical commissioning groups and local authority social care funding. And at that time, they said that the following regarding service provision, that service provision for people should be made available for those currently experiencing mental health problems, that services should be made available to promote prevention of mental illness and mental disorder, that there should be services with a focus on early intervention, so that's a focus on high-risk populations, and services to address mental health promotion. In theory, there was a recognition that service provision needed to encompass not just healthcare per se, but social care, employment services, supported accommodation services, and services to meet individual wider social, cultural, and spiritual needs, where these relate directly to the person's mental disorder and to help reduce the risk of deterioration in the person's mental health condition. However, sadly, I'm of the opinion that this does not appear to have been translated into targeted BAME mental health service provision. Finally, in thinking about the theme and about the topic I've been given to speak about today, I want to refer to the National Mapping of BAME Mental Health Support Review report by Carl Murray from the Black Training and Enterprise Group, which was released in August 2020. So Carl Murray led a study conducted between May and June 2020, and this survey sought to map the Black, Asian and minority mental health and wellbeing services in UK, with the aim of being able to start the process of capturing BAME-led mental health services, as well as to gauge an understanding of how these organizations are being impacted upon as a result of the COVID pandemic. Some of the highlights of that report was that there was an increased demand for BAME mental health services. However, there is a lack of BAME mental health provision. Mainstream providers and BAME-led organizations acknowledge that there is a lack of cultural competencies and perspectives in their work. Commissioners are aware of equality issues, but do not, and I emphasize that, do not factor these into the decisions they make when commissioning services. BAME-led service providers are in need of capacity building and infrastructural support. And there has been an increased move to online services, which has created a need for infrastructure to support migration from face-to-face to online interactions. And so the recommendations of that report for me are representative of greater investment and greater access. So the recommendations were as follows. One, in terms of bereavement support, the need for national BAME bereavement service that meets the cultural needs of the community, and bereavement therapists and service providers which have cultural competency that is quality assured. So, commissioners and funders of mental health, more, and I emphasize, more needs to be done in relation to funding, capacity building, and commissioning of BAME mental health services, especially around bereavement and mental health services. Then the next item was training in cultural competencies and race equality for NHS and statutory providers. And it was identified that there was a need for training in cultural competencies and equality impact assessments, and that there needed to be the recruitment and training of additional BAME counsellors, psychotherapists, psychologists, and mental health practitioners. Then going to the mainstream third sector providers and infrastructure organizations, it was acknowledged that there needed to be a joining up of services working with existing mainstream providers, such as Cruise Bereavement Care and the National Bereavement Alliance. It also highlighted that there needs to be technical and awareness training around bereavement support, mental health awareness that is culturally competent by BAME-led organizations and providers. Finally, they highlighted that more research needed to be undertaken on the impact of COVID-19 on BAME bereaved families, and that the Department of Health and Social Care, in conjunction with NHS England, needed to develop a mental health strategy on COVID-19 and BAME communities. And finally, that policymakers, there needed to be a grant scheme for BAME bereavement services and mental health services. So finally, I just want to end my talk by addressing Enfield Council. I know that the organization that has invited me today is based in Enfield. And I went to look at some information on Enfield Council yesterday, and they said that they have a commitment to equality and diversity. The write-up I read highlighted that 39% of the working population in Enfield are from the BAME community. And they said that Enfield is committed to improving access services and the local environment for all. They highlighted that there was some deficiencies in terms of employment for those with mental health difficulties. And they stated that they were in the process of building a wellbeing hub that would support employment, wellbeing, enablement, and housing. And there seemed to be a push to state that their children and young people's services were equitable with other services in the country. However, bearing in mind what I've just read from the mapping report, I'm left with a sense that Enfield Council, most respectfully, has quite a long way to go. And I would respectfully ask that they look at those parameters that have been identified from that report and begin to work towards implementing them. At this point, I would just like to say thank you. Thank you for listening.
Thank you very much. It's very interesting to well experienced speakers, Dr. Shadee and Des Brown. Welcome. We've asked people to please put your questions on the chat so we can pick them up if you have any questions for them. We just have a few minutes. I have a question for Des that came from Sarah. I think she's the MD for CCG. The question is, Des, are there any areas where services are doing this better? I assume she's asking about some of the key practices you mentioned. So she's asking whether there is any good practice that Enfield could emulate.
I think if you're looking at some training, I know Barking and Dagenham as a local authority invested a lot in trauma training for their practitioners, their professionals. And it is quite a new concept, but I think it's something that is developing, and it's not the answer to everything, but I think training is important, especially for professionals and community service users. So I would say definitely get training around being trauma informed, and I think the council will take responsibility and push that across all services, because I think it will change the delivery, whether it be to young people and to those that are in need and those that are vulnerable. That's the only one that I can think of. One thing I can commend Enfield on, recently being on a meeting with Nexus, is how they're addressing, and they've reduced massively their exclusion rate from school for young black males specifically. So I was quite interested in the way they're doing that. So I want to commend them on that, and they've been quite intentional about that. And that's looking again, because often PRUs or school exclusions can be a pipeline to prison. So hence issues around stress, trauma, etc. can kick in. But yeah, I would say definitely training, and maybe unconscious bias. I think looking at training around unconscious bias is also important.
Thank you very much. I have another question for Dr. Shadee. He said, do you know if Enfield Council are looking at what is working in other boroughs? That's from...
I have to say that I don't really have any direct links with Enfield Council, so I'm not sure. But what I did do was try and read up a paper that they had pulled together summarizing their performance for the last year. And as I said, what they seem to be focusing on at the moment is children and adolescents, which is appropriate, but what didn't seem to be very clear to me was that it was culturally appropriate. And then they were focusing on this hub. They had identified that many people with mental illnesses are having difficulties securing employment, which is of course is a form of discrimination. And they had decided that they were going to build this hub, which would address issues such as mental well-being and employment. But if you look at that report, which I went through, the summary, which has actually just been released in August, so it's relatively new. I'm not sure whether Enfield Council has taken the time to study that, but I think it's really important in terms of what we're saying about greater investment and greater access in relation to BAME communities.
Okay, thank you very much. Another question we can take up quickly for Dr. Shadee. I will come back to that. Maybe I answer, I give you feedback to the question just asked. You see, we are in Enfield. If you watch what happened in the short video we gave before we started, it set the seed for these two topics. I will tell you that the services that are being provided in Enfield, anyway, the Black community are not involved in designing and developing the services. That's the key issue. okay? They provide, I think it's Des who mentioned it. If you provide services based on what you think people need, you will end up not meeting the needs of the people, okay? So it's involving the Black communities at the strategic level to plan and deliver services. It's what is lacking. For 22 years, I have been involved on the ground in trying to meet the needs of the community. So that is still lacking. When you talk about good practice is that you need to work with the people you're providing services for. And that is very, very required. The next question somebody asked, Dr. Shadee, is, hold on, sorry. The questions are coming fast and furious. Somebody's asking, can we define what is the use of the word BAME? Okay, so perhaps Dr. Shadee, you can, because you use that a lot, if you can define that.
Yeah, it's an acronym, isn't it, really, which is referring to Black and ethnic minority individuals. So that's Black British, Black African, Black Afro-Caribbean, and individuals from Asian communities and other minority ethnic groups.
Thank you very much.
So, as Des had said, that it's not a homogeneous group, really.
Okay, thank you very much. The final question I will take is about cultural training. Somebody is asking about the name of organization for cultural training. Well, you have come to the right place. Wellbeing Connect Services has the experience of providing managing cultural diversity training, which actually won Enfield Good Practice in 2001. But after that Good Practice Enfield war that Enfield got, still things haven't improved as it's supposed to. So if you need cultural diversity training, please contact Wellbeing Connect Services.